Good afternoon, everyone. I'm Krista Drobak with Serona Strategies. Welcome to our third webinar in our vaccine distribution series. The other two webinars are posted on our website and the recordings can be accessed. The recording of this webinar will also be posted if you want to go back and watch it for a second time. Questions are going to be handled in the chat, and we will hopefully have some time at the end for some questions, but they'll all be handled through the chat, so you can post them throughout the webinar, and one of us could potentially answer them while we're still going. So there's a lot of topics to talk about related to the vaccine, the distribution, and which vaccine, et cetera, et cetera. But today we're going to be talking about data reporting. We've heard a lot of questions about how the data is going to be reported and which systems are going to be used and how the systems work together. The CDC is requiring that vaccine providers who are enrolled in the COVID-19 vaccine program report certain data elements for each dose administered within 24 hours of administration. And if you have access and it's online, the jurisdiction's operations book for states, it's actually all detailed in Appendix D. So you can see more information there. But I don't know about you, but for me, I was hearing all these different systems, state level public registries, the IZ gateway, the vaccine administration management system that is a new system being built by the federal government, Tiberius, and then thinking about how EHRs fit into all of this. So we decided that we wanted to hear from some experts, and I'm very honored to welcome a very esteemed panel that we have here today who have been working on these issues tirelessly. We're going to hear from Rebecca Coyle first. She's the executive director for the American Immunization Registry Association, and she's been in this vaccine world for 18 years, and she oversees the development and promotion of tools and best practices to support immunization information systems. And so she has a master's degree in education and has always emphasized public health. Then we're going to talk to or hear from Susan Pierce Richards. She's a nurse practitioner, a nurse informaticist, and an active duty public health service commission corps officer. She has been deployed to the CDC vaccine task force and is managing the VAMS system, the Vaccine Administration Management System. She's the lead over there for it. And she has over 20 years of clinical experience. And I was reading her bio this morning and thought, my goodness, she has a lot of experience clinically in primary care, emergency care, urgent care, women's health, forensics, and clinical informatics. She is a doctor of nursing, and she's also a family nurse practitioner. So welcome to Susan. And we have Hans Buitendijk. He is the director of interoperability at strategy at Cerner, where he focuses on establishing, promoting industry standards that enable interoperability. He represents Cerner on a variety of organizations, and today he's here as the chair of the executive committee of the EHRA Association. So we're very happy to have Hans, and without further ado, I'm going to turn it over to Rebecca.
Thank you so much, Krista. It's really a pleasure to be here today, and I appreciate you reaching out on this very timely and important topic. So if we can go to the next slide, I just want to note, as far as level setting goes, I feel like it's always important to sort of give you the overall big picture or background of sort of what present day landscape looks like. So the next couple of slides are primarily background. I'm going to kind of move through them rather quickly. So I want to get to some of the meat and potatoes of the conversation today. So next slide, I want to just briefly discuss, and show you all visually, what is an IIS. So these systems are really designed to be confidential and population-based. They are computerized, and they've been around for 20 years, really almost 30 years in some situations. At the core, they provide a consolidated and comprehensive record for an individual that can move across platforms, and it can move across different types of systems and be accessed by a number of different types of providers. So whether that's a pharmacist, it might be a family practice or the emergency room. The portability of this comprehensive record is really sort of the core of why immunization information systems were developed. You can also see on here there's a number of other key features like generating reminders so that if there are subsequent doses needed. And it also can work with the different programs to order and manage vaccine inventory. Next slide, please. IAS are located in all but one state. New Hampshire is our little gray state up there, but they are working fast and furiously to implement their IAS. So hopefully next year we will have all 50 states with an IAS. But I also want to point out that they also exist in other areas as well. So in New York, there is both a city and a state system. Likewise, in Pennsylvania, there's a system in Philadelphia and also in the entire state. All of our territories and freely associated states also operate a system as well. Next slide, please. In terms of what exists within a system, it is important to note that, in the childhood range, so that children 0 to 6, there are about 96% of all U.S. children that are in an IIS today. Actually, I shouldn't even say today, as of 2019. Likewise, for adolescents, there's about 82%, and in the adult category, we have over 60% of the adult population that fits within this group. I just want to highlight the adult group because I think it's one of those where that's certainly we're going to be targeting this population for a COVID vaccine. And a lot of people are like, oh gosh, there's still 40% of the adults that are not there. But I want to say, looking at where you need to start from, we have 60% of the adults in these systems, which is a tremendous starting point. If we were starting with 0, I'd be a little bit more concerned. So I'm actually thrilled that the number is as high as it is. Next slide, please. Just shifting a little bit in terms of how IIS are governed and what the policy framework is around these. So all of our jurisdictions, and jurisdictions include both state and local immunization programs that operate in IIS, it is up to their jurisdictional health authority to really set the policy and implement the system. So maintenance, update, all of the other fun stuff falls to that jurisdiction. The other piece that's really important is the policies that surround the operation of these systems. They are at the state and local level. So there are some policies that will have an impact on how a system can operate. The example there is most of our systems are opt-out, meaning that information can flow directly from an EHR directly into an IIS. In a couple of our states, there are still laws that require someone to explicitly say they want to go into these systems. So there is sort of a patchwork there when it comes to policies. The other big piece is how data can be exchanged and with whom it can be exchanged. And again, that is at the state level. There's not an overarching federal policy that really provides that framework. Next slide, please. So you saw sort of at a high level how much information is in an IIS. It's important to know where that information is coming from as well. So for our childhood immunizations, a lot of our systems are populated with vital records information. So those birth records are flowing directly into the IIS on a weekly, monthly basis, depending upon how that is set up. The old-fashioned way where you actually pull up the user interface, you can directly data enter that. That is sort of a thing of the past, but that was the original intent of registries. And again, these predated broad adoption of electronic health record systems, which is our predominant way of how information is flowing today. So by and large, EHRs, the information is keyed into these systems, and then that EHR has a pathway to exchange data with the IIS at the jurisdictional level, and that data often flows very seamlessly behind the scenes. In fact, we often know in large healthcare systems that perhaps a department that administers vaccines doesn't even know that there's a registry, but yet their information is flowing directly from their system to the IIS. Some other key partners are pharmacy systems, and then there are still a host of other systems where information might come like from a skilled nursing facility or nursing home that might be operating some sort of electronic system, or maybe they're leveraging some other intermediary as well. All right, on the next slide, I just want to sort of shift our focus and talk about standards, because I think standards are sort of the framework for how we need to be thinking about these systems. On the next slide, I just want to talk about from our perspective and where EHRA sort of fits into all of this we're an organization that sort of sits in between both the state and then also the federal folks at CDC, and where we try to pull together the community as sort of the broader group of folks to help develop some of these standards, and then work with the jurisdiction to provide technical assistance to implement those standards. And then now we're also at the point where we're measuring some of that, which I'll talk about shortly. So in terms of the spectrum, I think we all acknowledge that standards are critical. If we don't have standards, you have a hodgepodge of things and how they can operate. Within the IS community, we have a variety. So we have our formal standards, which are the HL7 implementation guide, which is developed in conjunction with CDC. There are also some select standards out there. So an example of that would be the SOAP Web Services and the CDC developed WSDL. And this was selected and adopted as the common transport method for immunization messaging. And that was done a couple of years ago because there needed to be a standard selected for that particular process. At a less standardized way, but more of a, hey, we really think you ought to do this level, there are guidance documents for how you should be doing something, but it's not quite at the level of being a formal standard. Beyond that, we have consensus-based recommendations where we're able to pull together subject matter experts from the community to help identify this is the best way we should be doing something, so that as jurisdictions and others are trying to adopt this, they have a framework for how to go about doing that. And a really good example of this is the onboarding consensus recommendations that were developed a number of years ago. And this was an effort where we actually pulled together folks from the EHR community. We pulled in some of our big EHR vendors, and then also subject matter experts from the IS community to collectively outline exactly, from start to finish, who's involved in the onboarding process and who the responsibilities lie with for each of those key areas. And then lastly, there's sort of the best practices where it's, maybe an emerging topic or trend, and what are some people doing and what are some of the best ways of doing it that they have found. So it's more of that informational area. And some of these topics maybe started a best practice and ultimately wind up as a formal standard. Others never go beyond being just a best practice. This is the way to do things. Next slide, please. Some other key tools and areas to help with a standardized approach. EHRA started a venture a couple of years ago on the address cleansing and validation side. So what this entailed is a contract with Smarty Streets, where we have a shared license that's available to all of the IS jurisdictions to use with their patient and provider data that can actually validate their address. And keeping in mind that when you can validate an address, you can actually increase patient matching, and you can increase provider matching. And I think, across the board, there's about a 3% increase in patient matching, which is tremendous when you're really looking across all of the systems. That's wonderful. So we have this available to all of our IIS, again, and it's sort of that collaborative approach. On the next slide, please, I'm going to talk about how we measure standard alignment. So I mentioned that we've sort of done all of this effort to develop the standards, but it does really no good if we don't actually know that those standards have been implemented and that they have been tested. So a couple of years ago, this is a community-led effort in the EHRA community IS crew kind of pulled together and really developed an objective test method that looks at what an IS is doing against the standards. And so there's a well thought out process there, but in the end, the testing is actually conducted by EHRA, and we connect with the pre-production systems, or in some situations, depending upon what it is, we're actually looking at analyzed de-identified data to really evaluate the adherence to standards by jurisdictions. On the next slide, please, I want to show you some of the results of that. So, for example, the outcome, and ultimately that's what we're looking for, right? We want to be able to make sure these systems can be leveraged and are useful. When we started some of this, looking at the standardized patient searches and where we saw some major improvements, IIS, when they're queried, they should respond with a complete immunization record response profile for that person that was queried. In 2017, there were 21 IIS that were able to provide that complete immunization record. through a lot of these efforts, when remeasured again in this year, 45 IS were able to provide that complete immunization record. So we, that's ultimately what we want to see is that increase in all of this, making it more usable for all of the different parties that are involved. Next slide, please. In terms of patient searches, I think putting it into context, you can see across the board, this is the average patient searches in 2020 by different jurisdictions. To break that down, that's about 11 million searches per year for a patient, 4 million a month, and on average, 135,000 queries per day for just one IIS. So that's a lot of different patient queries out there, which I think is great because as we're talking about rolling out patient queries for multi-dose COVID vaccines, this is going to be really important. Next slide, please. Let's sort of shift and talk about what that COVID vaccine response looks like. So on the next slide, just at the core, I think Krista did such a nice job of sort of highlighting that there are a lot of new partners and a lot of new systems that are sort of being pulled into the mix for this vaccine response. So I think it's really going to be important and essential that we're able to link not only the doses that are distributed, but also the doses administered and with the right person. So we know that ISs are planned to be the source of truth today and then also in the future. Again, kind of going back to that framework and setting that standardized approach, if we don't have a standardized way of capturing, organizing, and transporting these messages, we're not going to do a great job. And the good news is that we have that in place today, and now we're at the point where we need to action that. On the next slide, please. And this is really probably not, I'll just cover this briefly, but again, I think Susan is probably the best person to speak about some of the CDC responses. But in terms of the how states are operationalizing this, so CDC released a playbook back in September, and then states had to create their response based on what was in that playbook and submit that to CDC in October. So since that point in time, there's also been an updated version of the playbook, and that came out on October 29th. If you're interested to see what states included in their plans, there are a number of resources out there, one of which is maintained by the Association of State and Territorial Health Officials, or ASTO, and then another one that I just saw recently is the Kaiser Family Foundation. So those are some options for you to look at. On the next slide, please. So just drilling down, I think, sort of to see, where states are planning to be, at a glance. And again, this changes on a daily, hourly basis. So what you see in this slide is really relevant for today, but may not be in the future. But at a glance, we know that a majority of the ISs are going to be leveraging that over 117,000 electronic interfaces that are already in place with EHR and clinics today. And we know that these interfaces are going to support both the submission and query so that EHRs can query for that second dose information. We know that there are about 11 ISs that plan to use the CDC's Vaccine Administration Management System, which Susan can talk to you about here shortly. And then we know that another 12 sites will use other types of mass vaccination tools like PrepMod, and Salesforce has another system out there as well, and that will feed into IIS as well. Next slide, please. So, and as far as data sharing considerations and how data will flow, I think it's important to note that, what happens on day 72 might not be what exactly happens on day 1, recognizing that there's sort of a rollout. And first day, there's going to be, some opportunities identified that can maybe be actioned before the response really gets underway. But on day 1, IIS are planning to capture the identified information locally and then share de-identified information with CDC that can help inform that federal response, seeing where vaccines are going and who is receiving those. So CDC has noted within their data use agreement that later efforts may include requesting identified information or also leveraging privacy-preserving record linkage, or PPRL technology for sharing information with the federal government. So I do think it's important to note that I mentioned each state or jurisdiction has policies in place and legal considerations. We know that about half of our ISs out there have cited some sort of policy or legal restriction for sharing identified data with the federal government. So there are going to be some concerns or challenges that have to be overcome. And then I think just many of you are probably familiar with the PPRL, but I do think that, long-term, this actually may be a real blessing, and that it's really a technology that will provide a true benefit beyond even COVID. So I think we're kind of excited for that as well. Next slide, please. I just want to talk very briefly about the interjurisdictional data exchange. So there's a need to share information amongst jurisdictions. Today, there are 33 jurisdictions that have signed an interjurisdictional MOU that can legally exchange data across the state lines, and you can see, sort of at a glance what that looks like. The green are the ones that have signed the MOU. The blue are the ones that are active on the IZ Gateway share, and then the striped ones can do both, which is ultimately, I think, where we're wanting to go with that. Next slide, please. In terms of data access, I know that our jurisdictions are working fast and furiously to onboard new providers, new partners, and really expand the list of existing and new interfaces that are out there. But I do think it's important to note that our IS also have sort of old-fashioned user interface where you can log on to the website and you can actually key in that information. And so there is still a way to capture information, even if it is not in a seamless electronic way. Next slide, please. So just to sort of recap, I think the question is, are we ready? I think it's important to recognize that we have over 25 years of standardized or standard-based development and experience that is really going to lend itself nicely to a more coordinated and hopefully seamless COVID response. Our IS staff they really are staffed by dedicated folks who know this, have been around for a long time. But I think most importantly, they know their community. They know where they need to leverage resources and what that looks like within their jurisdiction, because it's not going to be the same across all of our jurisdictions. And while we know that this is a trying time and resources couldn't possibly be stretched any thinner, I think it's important to recognize that partners like EHRA and CDC and others are really pulling together to really try and help one another through this process and really lend our expertise in areas to help make this as seamless and painless as possible. So with that, I will say thank you, and I'm happy to take questions in the chat and turn it over to Susan.
Great, thank you.
Thank you, Rebecca. I'm gonna share my screen now. I have my own set of slides, and let me go ahead and share that. Can everyone hear me? Okay, it's not letting me share my screen.
Ellie, can you give her the rights?
Yes, you should be able to now.
Okay, here we go. All right. Can you see my screen?
Yep, we can see it.
Let me move that. Is that better? So you can just see my screen. All right. So good morning. I am Captain Susan Pierce-Richards, and as Krista said, I am the lead for the Vaccine Administration Management System, VAMS, with the CDC. I'm going to just give you a brief overview of VAMS. I will caveat up front, as she had indicated, I am on deployment from another agency to run VAMS. I do have a lot of experience in running software development projects, national scale software development projects for federal agencies. So I was brought on board, but I pretty much stay in my swim lane. So from the perspective of being fairly new to the CDC environment. So if there's any questions that come up that I don't feel comfortable answering, I'll be happy to try to get answers for you. So Just to start with a brief overview, VAMS is a web-based vaccine administration management system, and it supports large-scale vaccination operations and providers in near real time. And it's particular to the COVID-19 vaccine administration and that response. It is free for public health approved clinics and can be used on computers, tablets, and other mobile devices. We went live on 10/26/2020, and what I mean by live is enabling jurisdictions to begin to set up clinics, identify employer organization groups, and those are the groups that will be recruiting recipients. The recipient side is not open yet and won't be until vaccine has dropped and we actually have vaccine inventory so that they can begin to schedule their appointments. So one of the good features and nice features about VAMS is it does allow you to target specific cohorts of populations, which is going to be really important in that phase 1A, 1B, and phase 2 rollout. So the VAMS is composed of 4 portals: jurisdiction, employer organization, recipient, and clinic. And each of these modules has one user group except for the clinic portal, which has 4 user groups. In the jurisdiction portal, the jurisdiction points of contact are able to identify employer and organizations with individuals who need to be vaccinated. So it's really a recruiting tool, allows them to identify sites for vaccination clinics. So that will take those credentialed providers and allow them to begin to set up their clinic environments so that they can begin to have a patient schedule. Activate and manage clinics and employer organization accounts in VAMS, manage inventory requests, and track and monitor vaccine metrics. The clinic module contains 4 roles that support a variety of operations. So the clinic administrator can set up and manage their clinic, and the clinic schedules, monitor and manage inventory, assign roles to other clinic staff, and the roles the clinic administrator can assign include inventory manager, and that would be an individual who can manage the inventory. They may add inventory to the clinic, document wasted doses, and send inventory requests to the jurisdiction. The actual vaccine ordering is managed outside of VAMS, so this just allows you to see the inventory that's inside your clinic and allow you to send requests for inventory orders to your jurisdiction. We are working on a less labor-intensive way to move those order requests around for a future release. The front desk is a person who can check on recipients, and they can create walk-in appointments and cancel appointments. This front desk can also see if the patient has done their sort of pre-appointment questionnaire, so that they can direct them to go into their smartphone and do that if they haven't done it already. So this sort of helps the clinic flow. And then you have the healthcare professional, and that's a person who can view, modify, cancel recipient appointments. They can see the sort of medical information, the screening information, medical history, and the vaccine screening questionnaires, and document, of course, the vaccine administration. They can also document refusals, deferrals, and document any doses that they might waste during the process of vaccinating that particular patient. And the clinic types that are supported, so we have standard and mobile clinics that support vaccine recipients who self-register. So the one type of clinic would be one where you expect that you're going to recruit a patient, they're going to self-register, they're going to self-schedule, they're going to electronically do their screening questionnaire in advance of the appointment, they're going to receive their vaccine information statement or their EUA fact sheet, and then you will vaccinate that clinic. Now, it might be a fixed location where you have a building and they come in, your health department or your hospital, but it also supports that sort of series of clinics that you would do out in the community. So you're at the high school one day or at the Civic Center the next day, sort of a mobile clinic. There's also another type of clinic called third party. And this is the type of clinic that doesn't require recipients to self-register. So this would allow jurisdictions to establish vaccination clinics that facilitate things like a long-term care facility or a prison, but it also could be a a clinic that is supporting individuals that cannot, for some reason, self-register. So it might be that they have a technology challenge or they have a language challenge. And so this just gives you another avenue. So this particular type of clinic presumes that the identification of patients and scheduling is done outside of VAMS. It also presumes that the facility determines the process. So again, they don't self-register. Instead, the third-party clinic is responsible for uploading a list or individually adding patients, administering the vaccine sort of as part of that usual course of care, and then documenting when the vaccine is administered. So this allows you to have more of a closed pod. It does require that you have a recall system that's outside of VAMS. So again, this might be something that you run at a homeless facility or a group home, and then you need to make sure that you have a mechanism for recalling those patients for their next dose, or you visit them back again. So the next portal is employer organization, and this facilitates identifying and reaching out to individuals and allowing them to self-register. So this is their sort of recruitment tool. So again, these recipients would need to have internet access and email and ability to navigate the process or have somebody to assist them. And this is, again, why we also developed the third-party clinic, because obviously not everyone can do that, and particularly some of the sort of higher risk individuals or more difficult to reach individuals. But for those who can, this is a terrific way, and it has built-in recall system, which is great. So there's two ways. You can do a system-generated emails based on the individuals that you actually upload. So you put in a name and an email. You can also do what's called a policy-enabled registration. So you can use up to 3 organization-specific emails that you then have a single link and you blast it out to whomever you're trying to recruit. And they're only allowed to register if the email domains match. So again, it just gives you another tool. And then the final portal is the vaccine recipient portal. Once registered, the vaccine recipient can access this module. And in the module, they can provide their preferred method of communication, so email or text. They can answer their eligibility questions, that sort of pre-vaccine screening questions around medical history and whether they have allergies, whether they're pregnant, et cetera. It also allows sending them a link so that they can review the EUA fact sheet or BIS, whatever is available at the time. They also will get a reminder about returning for a second dose. They can download their vaccine certificate. They will also receive a message about how to report vaccine adverse events and be invited to participate in the VSafe efforts for vaccine monitoring. So I'm just going to quickly walk through one of the clinic workflows that VAMS supports. So this would be the self-registration, self-scheduling workflow. So after the CDC, So after the CDC assigns a selected jurisdiction staff to the jurisdiction point of contact users, the jurisdiction point of contact would activate that clinic, and the clinic administrator is in their jurisdiction. And the jurisdiction point of contact also activates the employer organizations. So the clinic administrator would then assign healthcare personnel, front desk personnel, and inventory managers to the clinics. The clinic administrator sets up the schedule, and they or the inventory manager loads inventory into the clinic. And you can just kind of have an idea of what it looks like. Likely concurrently, the employer organization would upload a roster of individuals that are candidate recipients for the vaccine. For example, it might be healthcare personnel. They also could have an organizational email, whatever the hospital is, and send a blast out to recruit folks to come in. So again, it's pretty easy. You can add an individual. You can upload a list from an Excel spreadsheet based on a template that we provide. And just to be really clear, So the employer organization is not involved with actual vaccine administration. So this is really primarily a recruiting tool. So this just allows organizations and employers to identify the target groups and funnel them into VAMS clinics that the recipient will be able to access. So once uploaded into the system, you have that list of patients where you send the email blast. The individual can then register. So they can click on whatever link. So if it's a policy enabled, they click on the link and it checks, validates their email, or they have an individual email that they get based on being uploaded into the organization list. So they can now add their demographic information, medical information, and schedule an appointment. Before the appointment, like I said, they'll receive a reminder to fill out that pre-vaccination questionnaire, and they'll also get a PDF or a link to that EUA fact sheet or VIS, whatever is available at the time of their appointment. And so you can see this is where they would begin to enter the information. We have not finalized all of the questions because we're waiting to see the EUA from the different vaccine manufacturers to finalize the language that's in the portal. And it's one of the reasons why we haven't opened the recipient portal yet.
Susan, can I ask a quick question? So this public facing part of the tool is for like individual patients to go in maybe through the CDC website and register themselves to receive a vaccine.
Well, initially it's not going to be open to the public in the early rollout. In the early rollout, the only folks that will have access to the portal will be funneled through this recruitment tool. So you would be identified by an organization or employer, and you would either be sent a link to use to register, or you would get that policy enabled link where it's like, hey, if you have a CDC email, then you would be able to register. And the reason it's structured this way is because the anticipation of especially phase 1A and B to be targeted at those critical infrastructure. So we are working on what it's going to look like when we're further down in the rollout, and we need to support broader use of the VAMS.
So
So in the future, it might look like that.
If you're a long-term care facility that's opted in to receive vaccine from one of the designated pharmacies, the pharmacist comes in and does the vaccines in the long-term care facility and uses VAMS to report it. Does VAMS then push out to the EHR so that the patient's doctors know that they've gotten the vaccine, and or does it push out to the IIS registries?
Yeah, I'll get to that. It pushes out to the IIS. The other thing is that if a pharmacy went in to do a long-term care facility, they wouldn't use this workflow. They would use that third party where they would get a list of the vaccine recipients and then they would document it that way. So a long-term care facility likely would not use a workflow where the patients register. They would use third-party clinic where the vaccinating organization came in, did that pre-screening, made sure that all of the appropriate authorizations were there and would document it. But it would still be documented in VAMS. So once the vaccine recipient arrives at the clinic, and as long as that pre-screening questionnaire is already complete, the front desk can check that patient in. The professional who's doing the administration can review the medical information on the screening and make sure it's appropriate to vaccinate. So ultimately, it's the vaccinator that determines whether the vaccine is administered, obviously, and then they can enter the appropriate documentation. And again, if they determine that the patient shouldn't get it, they can document that it's deferred or that they're not going to provide it. They can also document if they dropped a vial or wasted a dose during that process. Now, once the vaccine is administered and documented, the recipient immediately receives a message to schedule the next dose. And they can go in and they can schedule it. The system will only show them appointments that are after the appropriate interval has passed for them to get their second dose. So if they get a vaccine today and they schedule their next appointment, they won't be able to schedule one that's sooner than, say, 21 days, if that's the appropriate interval. They will also receive a reminder if they didn't do that scheduling, and they can log in any time and print their vaccine certificate if they need to give it to their employer, for instance. And then once the vaccination is complete, the VAM system creates an HL7 message and it transmits it. And if the traffic is high, there may be a sort of a system hold and they may queue them, but they certainly will not go beyond 24 hours from transmitting that vaccine event. They anticipate that if there's heavy traffic, maybe they have to hold it for 5 or 10 minutes or an hour. But the idea is that it would be near real time or real time. Now, the pathway for sending the messages is from VAMS, and then it's going to go to the IIS. As Rebecca mentioned, there are data sharing, different data sharing rules and laws based on the jurisdictions. And so it may or may not push that message to the CDC. So again, when folks onboard to VAMS, they have a discussion with the integration team with VAMS and determine what the data sharing agreements are. And then that determines whether the data gets just pushed to the IIS, and then the IIS incorporates it and then submits that de-identified message up to the data clearinghouse and IT data lake. But if they are allowed to share and they're using VAMS only, then it will do the reporting on behalf of the jurisdiction. So again, a lot of those details get sorted out during the onboarding process. So the data doesn't flow directly to an EHR. It goes from VAMS to the IIS. It may also go to the CDC, and then the idea is that an EHR would have a query where it would look to the IIS. Again, that IIS as that source of truth. And again, the eventual data flow is going to be through that IZ gateway. Day one operations are going to be a little bit contingent upon when everything is ready. But again, they're working individually with the different jurisdictions that are using VAMS to make sure that they can get their data and they can get it in a timely fashion and that everything can get reported on time. And that is all I have, unless there are questions that you have for me. And then of course we will look at the questions in the Q&A
yeah,
box.
that'd be great if you could, if there are questions that come in through the chat. And Jamil, we'll go to questions after we hear from Hans.
All right.
Thank you.
So my name is Hans Buitendijk and chair of the EHRA Executive Committee. If you can go to the next slide, many of you may not be as familiar with the EHRA. It's an organization of about 29 members, companies that provide EHRs to hospitals, clinics, practices, post-acute care, and cover as a result about 80–90% if you when you look at the hospitals and clinics that have an EHR. Many of them are also certified for a variety of capabilities as part of the certification, meaningful use, 21st century cures initiatives, etc. And the purpose of the organization is to really work together where we can to have an opportunity to look at the common needs that our clients have and interact with agencies, HHS, Congress, industry initiatives, groups to help provide a perspective on EHRs and also a point where we can have communication from those organizations with EHR vendors at one point in time. And particularly that last part is what is important and critical in what we are talking about here. So as we started to be involved, it clearly was from the get-go the moment that it started. If you go to the next slide, is that from a COVID perspective, a statement here is that we have been in the middle from the get-go because patients were admitted, were being scheduled. There was a need to extend. So if you go to the next slide, all the different parts where whether it's identifying patients, enabling reporting in the triage specifically for COVID, any communication that's out there, reporting on resources, etc. They all are connected to or are sourced from data from the EHR, or they're performed right inside the EHR. Vaccinations is clearly one of the parts there, and that's the point that we have started to arrive at now. So in many ways, when some of the questions that we have received is about, well, do you have VAMs? Do you have EHR? Do you have both? And as Susan also indicated, is that they're in effect different systems have an overlap in their capabilities, and it depends on what an organization that administers vaccinations has, whether they have one or the other. It is not meant that you go back and forth between the two to manage an individual administration, but it's still possible that an administration occurs in a clinic or in a location that uses VAMS, the VAMS environment, and then because of travel, because of moving, because of whatever, the next time around for the second administration, that's happening in a clinic or a setting that uses an EHR, and vice versa. So there are interaction points, but they are more across administrations than within one administration to manage that. If you go to the next slide. So while we went through the COVID pandemic, the EHR Association set up a task force, and that we really started to focus on engaging with federal agencies. So we have been throughout reaching out, and they've reached out to us, whether it's CDC, initially some FEMA, more since that time, HHS CIO office, ONC, with other organizations that we are trying to stay informed and enable information to flow to our members, as well as the other way around. So over the last couple of weeks in particular is where we have been focusing a lot of time on learning more, figuring out, does everybody know what we need to do around vaccine administration? So looking at that at the next slide is where we have obviously started to get access to the interim playbook. And we had a variety of questions around code sets around vaccine administration. And still working through that, because the intent is to ensure that by the time the vaccines are available, that all our systems are set up, ready to go, which starts with what are the codes that can be used to document vaccinations and as well interact then with inventory systems and interact with patients, provide the appropriate information. So some of the areas that one of them already being mentioned, waiting for the EUA to come out, where typically the VIS is in play. How do we get that information out, given that it's an EUA and not a VIS, since we're not quite there yet? Questions or information around expiration dates. What do we use? Where's the barcode to use, etc. So there's a number of different things in that space that we have been looking at. Scheduling, where a person is ready to schedule, then at that point in time, it's interacting with the clinic that may have either VAMS or an EHR where that happens, where they may have found information on Vaccine Finder that then gets them in touch with it and needs to follow that scheduling process. Once we get then into the EHR beyond the scheduling, the eligibility, validating that and making sure that's followed, which can vary by jurisdiction. So EHRs that are supporting clients that are interacting with different jurisdictions, we will have to accommodate a variety of different rules and guidance that's helpful to be included. Another important part is that vaccine certificate. As Susan indicated, is that once this, a vaccine is administered, it's being reported to the IIS in that jurisdiction that then communicates that forward. An EHR would communicate with an IIS using a query, but that might have happened in another jurisdiction. So there's a couple of dependencies to get that information. So we are going to be dependent on a variety of different techniques to get the best information, including the patient having access to their certificate as well, and being able to help ensure as a result that the second vaccination happens at appropriate time. So there are still some things that initially there may be some dependence on the patient, and over time, as IISs are further connected, queries to that IIS, and then beyond that as to where the patient has been, otherwise that we can get a full record of the patient vaccinations, including COVID. So there's still some areas to be worked out in that space. The administration reporting, Rebecca already talked about it, Susan already talked about it. EHRs are connected with IISs, but not necessarily all of them, based on where they're at with their infrastructures. So there is also the notion of a flat file, that where there is not that connection, that can be utilized to submit the administrations. There are some state variances that we have to deal with. So the areas that we're currently looking at specifically then is that, are there places where we need to enhance V2 messages for particular jurisdictions? And where that is not in place, is there a consistent flat file format that can be used, and that may still need to be augmented with additional information that they are interested in? We know of a couple of scenarios where there will be variances out there, and we have to address that since our clients are across the spectrum across the country, and have to interact with different jurisdictions, or depending on the location of the client, they may interact accordingly or need access to that information as well. Follow-up is the other part that EHRs are going to also be working with, obviously, in terms of notifications, next administration, ensuring that the timing is appropriate. So those are the kind of capabilities that an EHR would then enable the client to do, a provider. And lastly, adverse event reporting, currently done through portal. So immediately, we are not aware of or expecting that there's an electronic submission, but we do know that there's activities going on in the industry to start to, over time, address that as well, so that that can be further automated as well. So clearly, EHR plays a role in it. That the way I'm trying to think about it, and Susan will correct me if I'm not quite in line there, but VAMS and EHR from a clinical documentation and reporting perspective are very similar in their capabilities that they are providing their providers, but not everybody has an EHR. So that's where VAMS comes in. And then the interaction with the jurisdiction where they already are providing that is very similar, as Rebecca talked about. We are really building on a lot that's already there, which is great, but that doesn't mean that everything that we need to make it run even better, that are not areas that we need to continue to focus on. So that's where the EHRs sit into this, and extend their capabilities to the clients in the space where they have that ability, and many of them do, where that's appropriate. Some might not. And that's also then where VAMS may come in. So you see a varied landscape in that regard. So I'm going to stop there and pass it back to you, Krista, that any kind of questions. This is effectively already covered that with the basic flow between Rebecca and Susan. And
maybe Ellie, leave this slide up just to remind us how this all works. So I have a question for all three of you. I am part of the 40% of clinics that are not enrolled in the IIS system in my state. I serve adult population, so I've never had a need to get enrolled. I now want to become an approved vaccine administrator. Can I turn to my electronic health record vendor to just work this out for me? Do I need to try to contact somebody at the state level to help me figure out how to get enrolled? Or do I contact CDC to try to use the VAMS system?
Who wants to start?
I'm happy to take it. Yeah, Hans, do you want to take this one?
I think it probably is a combination between the three of us, is that if you have an EHR, check with them and see what they already have in place. I should have drawn an additional line there with flat file that as an alternative to using the version 2 messages, that's a way to connect. But if you already know that your IIS is not connected with that, then you're starting to lean towards the flat file. If you do not have an EHR, then you start to lean towards the VAM. So depending on the situation that you actually have in place, your answer might be is that you can step to your EHR vendor and say, hey, let's make sure that works. But it depends on the IIS. Can they accept that? Is it already in place? Do they need to get the flat file? And then if neither of those work in that time, then the VAMS is the alternative. And then the question is for Susan, what are the steps to then get that on board? And recognizes that you cannot go back and forth on certain administrations between the VAMS and the EHR. It's one or the other.
Yeah, this is Susan. I would start with reaching out to your jurisdiction point of contact for the COVID response to understand what the landscape is in the particular jurisdiction. They may have an electronic vaccine administration tool that the jurisdiction is using, or they may be a jurisdiction that is using VAMS, in which case they can get you connected with the process for provider enrollment. So there's a provider enrollment process to administer the vaccine as a vaccine provider, and then what IT system to use. And then if it's VAMS, then there's a pathway to get set up with VAMS. And that's through the jurisdiction. The jurisdictions are doing that.
And Rebecca, why wouldn't a jurisdiction just direct me to an IIS system?
Yeah, that's a great question. If the capabilities exist, that's the preferred route. So, I think going back to sort of what Hans had mentioned is, check with all of the above. But I will note just, at a high level overview of what's involved in an onboarding process. Again, this is how we want the data to be ultimately transmitted, is using that HL7B2 messaging. If you look at the onboarding guidance document that we developed in conjunction with our EHR partners, it really buckets out where the responsibility lies for providers, for the EHR, for the IIS, and what someone can expect in that onboarding process. So it's a good summary there. And then in terms of, I think just trying to get the data out there, that there might be long onboarding queues. I think about all the providers that are now trying to access and onboard right now. There might be a need to have some workarounds in the interim.
And Hans, what is an example of a kind of entity that wouldn't have an EHR system? Oh, you're on mute. Maybe some of the long-term care facilities?
They may, but they may have them as well. So depending on how they have deployed, what role they currently play in vaccine administrations, a long-term care facility may or may not have that need today, and now they do. So that depends a little bit. Hospitals, clinics typically have one, but if you're in a mobile clinic or in other settings, you might not. So it really depends on it. I cannot really give you an exact dividing line because that depends. Okay. It also depends on did the EHR provide to them. EHR can be very big in terms of breadth of capabilities, and it can be more focused and narrow. Mm-hmm. It depends on what that organization utilizes, whether that includes a vaccine administration module or not. So it's really about that. It's not just do you have an EHR, but is there a vaccine administration module effectively that supports you in the administration, reporting, querying, etc.
Susan, do you want to get the last word here? I think I saw you talking.
Yeah, so I think tapping on what Hans said, which is it may be that you don't have a technology that's going to collect and report the vaccine administration data, but it also could be that you have one, like you have an EHR, but the workflow that you're trying to implement, you have a clinic out in the community where it's just not efficient or it doesn't match that workflow. So VANS can sort of be something that can be a partial solution for jurisdictions and organizations or a complete solution depending on what the technology needs are and the workflows.
Okay, we've hit the hour. We will leave this up for a few minutes in case our three speakers are able to answer some of these last questions in the chat. Again, this recording will be posted on our website. The Sirona website also has a link to all of the 46 state plans that are available. We'll be watching for the last 4, and so you can access them there. And then to our 3 speakers, thank you very much. And hopefully we can have you back in a few months for part 2 update on how all this is going. So thank you again. We really appreciate for your time. And I know that a lot of people are going to be very happy to have this information. So thank you.
Thank you so much.